podcast is not a replacement to any formal lectures or clinical placements. Hello and namaste to all. Welcome back to our podcast. I'm Anisha.
And I'm Kabita, and here we will have discussion on different clinical cases in this case series.
Welcome to the case series episode 3. A 35-year-old male with epigastric pain.
A 35-year-old male presents to medical OPD with a month history of episodes of epigastric pain. He is also having burning sensation in his chest for a year, and his symptom has worsened for about a month. The pain radiates to his back and is associated with nausea, hypersalivation, and occasional regurgitation.
Is there any association between the pain and food intake?
Yes, he complains that pain is usually experienced after having food, more with fatty diet. It lasts for 10 to 60 minutes and resolves by adjusting the position from lying down to sitting, and sometimes spontaneously.
And what about the severity of the pain?
It is a moderate severity which interferes with his daily activities like focusing on his official work.
So he is having moderate epigastric pain of burning character that radiates to the back and aggravated by food intake. Has he mentioned anything about problem in swallowing?
Yeah, he had difficulty in swallowing food and he also feels that there is something in his throat.
Does he have any significant past history?
He had similar symptoms few years back which relieved itself within 2 to 3 days. But now as the symptoms have not resolved even for a month but kept on worsening, he has come for consultation.
Okay, what about his personal history?
He is a chronic smoker. He smokes 12 cigarettes per day since the age of 20. He used to drink occasionally 5 years back. His sleep is disturbed because of pain and used to wake up from his sleep occasionally. And he rarely exercises.
Does he have any significant family history and medication history?
No, he does not.
Okay, now let's discuss about the examination findings.
Well, his vitals, signs and general physical examination findings are all normal. But his BMI is 28.
That means he is overweight. And what about his systemic examination?
There is no any significant findings.
Now, I think we are closer to our diagnosis. But what do you think are the differentials?
Diseases like gastroesophageal reflux disease, esophagitis, peptic ulcer disease, biliary colic, coronary artery disease, achalasia cardia can't be the differentials.
To reach the diagnosis, what investigations should be done?
Complete blood count and ECG should be done to rule out coronary artery disease, whereas barium contrast study, 24-hour pulse monitoring, endoscopy and esophageal manometry can be done to rule out gastroesophageal reflux disease.
What does his report says?
The blood test, ECG, esophageal manometry are all normal, but his 24-hour pulse is low.
So we should conclude GERD, that is gastroesophageal reflux disease, as our diagnosis?
I think so. The symptoms and signs are related to gastroesophageal reflux disease. Gastroesophageal reflux disease is a condition that develops when the reflux of stomach contents causes troublesome symptoms and/or complications.
Occasional episodes of reflux are normal and physiological, typically occurring postprandially. They are short-lived, asymptomatic, and rarely occur during sleep.
It is due to imbalance between injurious or symptom-eliciting factors like reflux event, acidity of refluxate, esophageal hypersensitivity, and defensive factors like esophageal acid clearance, mucosal integrity.
Now, let's discuss about the management. Tell me, Kabita, how will you proceed?
I will suggest for lifestyle modification first, then medical management, and lastly surgical management. Lifestyle modification consists of dietary modification, avoiding fatty food, coffee, alcohol, orange juice, chocolate, avoiding large meals before bedtime, sleeping with trunk of the body elevated, quit smoking, weight reduction, and avoidance of late meals.
Medical management can be applied when lifestyle modification fails or in combination with it. Medical management includes use of antacids and proton pump inhibitors.
Surgical treatment includes anti-reflux surgery if there is failure of medical treatment or respiratory problems due to reflux and aspiration of gastric contents or severe esophageal injury, that is ulcer, hemorrhage, stricture or bariatric esophagus.
So, what do you think would be best for our case?
I think he should be advised for lifestyle modification and management as he has been experiencing the symptoms since long.
Yes, surgery would be too early for him, but he should be called for follow-up after 2 weeks to assess if his symptoms resolve.
Yeah, you are right.
So, we learned today about reflux disease, which is one of the common problems.
And now we have come to the end of this episode. Thank you for listening to us. See you in the next episode.
Goodbye and keep learning.